Hi, everyone, and welcome. My name is Jeremy, and I am a representative of EHN Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have locations located in British Columbia, Alberta, Ontario, Quebec, and Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at ehncanada.com. Just in terms of housekeeping, everyone is on mute and cameras are off for today's webinar, but please feel free to use the Q&A box at the bottom of your screen to submit any questions for our speaker. We will try to get to as many questions as we can at the end of today's session. Please remember that this is a professional and inclusive space, and offensive commentary will not be accepted or tolerated. Today's webinar is being recorded, and we will be sending out a follow-up email sometime mid to late next week that will include a link to the recording, any useful resources, as well as your CEU certificate and a copy of today's slide deck. Cheryl and I are both located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee people, and the Wendat people as well. It is covered by Treaty 13 with the Mississauga of the Credit. If you are new to this work and want to find out whose land you are on or grew up on, please check out www.native-land.ca. Many more of you may be physically present elsewhere. I encourage everyone to use the chat function to, where applicable, share whose land you are on. Now, today's session, concurrent treatment, eating disorders and substance use disorder. We have Cheryl F. Cheryl has worked across the continuum of care in mental health and addictions, including the roles as an occupational therapist and psychotherapist in acute and residential adolescent psychiatry, acute geriatric psychiatry, early psychosis intervention, and transitional aged youth outpatient services. With 10 years of experience, Cheryl has held leadership roles in a residential adolescent eating disorder setting, as a project manager implementing a mental health and addiction strategy in primary care, acute general medicine, and in geriatric rehabilitation and palliative care. She has also helped to inform provincial strategy initiatives for individuals with anxiety and obsessive compulsive disorder and mental health transitions in care. At Bellwood, Cheryl is responsible for directing clinical services programming by leading strategic initiatives focused on providing evidence-based practices in mental health and addiction care. Please help me welcome Cheryl.
Thank you, Jeremy. It's nice to be here with everyone today. As Jeremy mentioned, my name is Cheryl and I'm the clinical director at Bellwood. And so what I'm going to take you through today is a conversation on concurrent treatment, specifically with respect to eating disorders and substance use disorders. So as I was going through and creating this presentation, I really decided that I wanted to hone in on two goals. First was making the case for concurrent treatment, and then to really focus on what we do at Bellwood and how we do that with respect to concurrent treatment for eating disorders and substance use disorders. So I wanted this to be a bit interactive. I'm certainly interested to know who is tuning in today. So Jeremy has launched a poll, and we will get you to provide your answers, and that gives me a great idea of who is here today. And people should see the poll on their screen, and you can just you can select one of those options. Wonderful. And I saw something come up in the chat really quickly about dietitian. If you are a dietitian, please feel free to select allied health. That absolutely should be included in allied health. I apologize. So it looks like most of our individuals are coming from that allied health category, at about 34% psychology, RP, dietitians, OTs, social work, behavior therapists, physiotherapists, among others. So we can go to the next poll. So I'd also like to know, in terms of where you work. Do you work for a hospital organization, a community-based organization, or are you part of an independent or private practice? And you'll see that poll up as well. So a large number of people are coming from community-based practice, which is great. And my final poll, I'm interested what area of practice that you work in. So do you work specifically in eating disorders, substance use disorders? Do you work in a concurrent eating and substance use disorder program, other mental health programming, or something else that's not captured here? Okay, so other mental health programming is the largest category, and then substance use disorders is the second, the runner-up, and then other categories as well. So thank you. That's very helpful for me to know as I go through this presentation, and we'll have a discussion about substance use and eating disorders now. So I wanted to make note, there's new data that has come out just this week from the Ontario Psychological Association, which really speaks to demand for mental health supports for adults in Ontario. So between 2021 and 2022, there was a significant increase in that demand at 47%, which is quite a staggering number in just 1 year. We know that there are significant impacts of the pandemic. I didn't include on the slide that rate for children and adolescents is actually much higher. It is the demand increased by 104% in that 1 year span. So I encourage you to go to the OPA website and check that out. It was just released, I believe, on Monday this week. So I wanted to make note of that as we go in. So ultimately, I go back to my first goal. So when we make the case for concurrent treatment, what I hope to emphasize here is that we can't do that without looking at the prevalence and the impact. And so especially when these two disorders collide. So when we look at overall general prevalence rates, there are approximately 1 million Canadians that meet diagnostic criteria for an eating disorder. So that includes anorexia, bulimia, binge eating disorder, avoidant restrictive food intake disorder, or otherwise specified feeding and eating disorders. And so anyone who's worked in eating disorders knows that they're very serious but treatable mental illnesses that can affect anyone regardless of gender, age, race, ethnic identity, sexual orientation, or socioeconomic background. When we looked at substance use disorders, I'll get you to go back one, Jeremy. When we look at substance use disorders in Canada, it is estimated that approximately 6 million people, which is about 21% of the population, will meet the criteria for addiction in their lifetime. Alcohol was the most common substance for which people met the criteria at about 18%. Cannabis fell behind that. And in Ontario specifically, there's an estimated 10% of the Ontario population that has problematic substance use. When we look at the overall prevalence of eating disorders and substance use disorders combined, there was a recently published meta-analysis on these prevalence rates examining the comorbidity between substance use and eating disorders. And so what that meta-analysis found is that the comorbidity of substance use disorders and eating disorders was 22%, and that was a pooled prevalence rate. But the prevalence rate of eating disorders among those who are seeking treatment for substance use disorders is 35%. This means that the prevalence of eating disorders in individuals with substance use disorders appears to be 10 times higher than the prevalence of eating disorders in the general population. And The prevalence of substance use disorders among individuals seeking treatment for eating disorders is somewhere between 25 and 50%. So what I'd like to highlight here is the impact of eating disorders. And so if anyone has worked in eating disorders before, you've likely seen this slide. This is a slide that's been around for a long time. And what you see here is that there is a significant impact of eating disorders on the body, both medically and psychologically. What that means for mortality rates is pretty significant. So while it's well documented that mental illnesses are a leading cause of premature death in Canada, it is less known that eating disorders have the highest overall mortality rate of any mental illness, with estimates between 10 to 15%. And it is estimated that 10% of those with anorexia specifically will die within 10 years of disorder onset. Cardiac disease is the leading cause of death, while suicide is the second leading cause of death among those with anorexia. 20% of people with anorexia and 25 to 35% of people with bulimia may attempt suicide in their lifetime. And for females specifically in the age range of 15 to 24 years old, the mortality rate associated with anorexia is 12 times greater than that of all other causes of death combined. When we look at substance use disorders, we see very much the same picture. So the body system impact of substance use disorders, both medically and psychologically. And so what you see in this graphic is on the left side of the graphic, you see the effects of prolonged drug use on the body, and then alcohol use is on the right side of the graphic. When I look at mortality rates specifically in substance use disorders, CAMH has this data available that 67,000% of deaths per year in Canada are attributed to substance use disorder. 15,000 of those are specifically alcohol related, and over 14,000 are opioid related. This data is a few years old, and given the impact of coming out of a 3-year pandemic, what we know is that rates of mental health and substance use have significantly increased. So the current data is actually is much more staggering, and so we'll be looking for that as it comes out. When I look at the impact of concurrent eating disorders and substance use disorders, what we see is that no body system is safe. And so I've put these two graphics side by side to really highlight that point, whether it is related to the brain, the cardiac system, the cardiovascular system, respiratory system, the blood system. The impact of those concurrent disorders together can be quite significant. And so what we know, therefore, is that when these two disorders are combined, they are more lethal together than either disorder alone. I have some data to support that specifically. I apologize about how the wordiness of this slide, but the data is quite staggering, so I wanted to highlight that for you. So when we look at combined mortality rates for eating disorders, comorbid eating disorders, and substance use disorders, when we look at compared with match controls of subjects without substance use disorders, specifically we'll start with anorexia, the risk of all-cause mortality was 3.21% times higher among patients with anorexia nervosa without substance use disorders, 11.28 times higher among patients with both anorexia and alcohol use disorder or cannabis use disorder, and 22.34 times higher among patients with both anorexia and a hard drug use disorder alone or in combination with alcohol use disorder or cannabis disorder. The data for bulimia nervosa is also quite significant. So all-cause mortality rate for those without substance use disorders was similar to their control counterparts, but with the adjusted hazard rate of 5.86 for those with comorbid alcohol and or cannabis use disorder, and 11.43 for those with hard drug use disorder alone or in combination with alcohol use disorder or cannabis use disorder. When we look at unspecified eating disorders, the adjusted hazard ratio was 4.75 for those without comorbid substance use disorders 10.86 for those with comorbid alcohol and or cannabis use disorder, and 15.53 times higher for those with hard drug use disorder alone or in combination with alcohol or cannabis use disorder. So these rates are quite significant. I want to make a note of when we combine these two disorders together, how significant it can be on treatment and treatment impact. So what we know is that eating disorders have been found to be significantly associated with decisions to leave substance use treatment against medical advice. So to stop treatment before they have completed a treatment protocol. And a recent study found that individuals with lifetime alcohol use disorder and nicotine dependence have significantly greater risk of broad anorexia, purging disorder, and many eating disorder symptoms than people without the disorders. And so this underscores the importance of addressing eating disorder symptoms among people with alcohol use disorder who also use other substances comorbidly. When we look at the shared risk factors and those comorbidities, what we see is that in both eating disorders and substance use disorders, they're typically associated with major depressive disorder, anxiety disorders, suicidality, which can include suicidal ideation, suicide plans, attempts, or even death by suicide, as well as impulsive behavior. There is also shared comorbidities of trauma and emotional dysregulation that is intrinsic to the pathology underlying a broad spectrum of psychiatric disorders. But I'll talk about trauma and emotional dysregulation separately in a moment. When we look more specifically at the shared risk factors between eating disorders and substance use disorders, what you see here are those common risk factors. And so the overlap between eating disorders and substance use disorders can be explained by shared biological, genetic factors, psychological, as well as sociocultural risk factors. And so these increase the predisposition to comorbid disease development as well as death. They also have the shared risk factors of temperament and personality and the shared relationship amongst those. When we look at that shared relationship specifically, I want to focus on the shared relationship between sensitive temperament, emotional avoidance and dysregulation, as well as maladaptive behavior and coping. So when we have a stressor that in someone's environment, especially in someone who may be what we sometimes hear being referred to as super feelers or super sensitive, what often happens is that when there's been that stressor in a person's environment, there is a response. And what comes out of that response is that it may be misattuned. It may be misattuned to the environment, but nonetheless, it is an experience and a response of that individual. And so what can come from that emotional response can sometimes be emotional avoidance or a person's needs not being met. And the more the intense the response, the greater the degree that that person feels that and experiences that. And so what we see quite often is maladaptive behaviors or people not coping and utilizing skills that are adaptive to help them to navigate this situation they may be facing. But what we know is that emotions are both necessary and adaptive. And when a person has needs that are not met, those emotions can become much bigger. And so when we see those maladaptive behaviors and coping, what we would see is sometimes engagement in eating disorder behaviors or substance use behaviors. So what we know is that when substance use and eating disorder behaviors are combined, they are very powerful together. And they're very powerful ways to stop a person from experiencing, that powerful emotional situation that they've just encountered. They might have had that misattuned response, as I mentioned, and then what we see is with this combined is that there is a very intense response, and therefore, if there is the need and the drive to avoid that, would be engagement in substance use or eating disorders behavior. And what I want to emphasize here is the function of that. That is functional for a person, although it may not be the best choice for them in the moment. It is functional. It serves a purpose to better attune to their environment and to regulate what they're experiencing. I can't talk about these shared risk factors without saying a few things about trauma. When we think about trauma in terms of, big T trauma as well as little t trauma. And so big T trauma might be things like that have happened in a person's life, such as an accident, witnessing the death of a loved one, the suicide of a loved one, or somebody that, a person is close to, a tragic event, the incarceration of a loved one. So typically big T trauma comes along with an indexed event where you can point to it and it's specific. In many cases, it is observable for the person, with of course the exception of sexual trauma. And so when we think about big T trauma, those are those significant events that we can quite often point to and say, this was the thing that happened in my life, and that was a driving factor for me to engage in that maladaptive coping. And it may not come right away. It may happen at a point later in someone's life. When we think about little T trauma, we think about things that are less observable. So someone who's experienced an invalidating environment, a mismatch of a parenting style to a child's temperament, the emotional absence of a loved one, systemic issues like racism and discrimination. These are all things that over time tend to have a culmination effect. And so that culmination of experiences for that individual can significantly contribute to one another. And so we may not notice that in the moment. We may not see it as a formal index event, if you will, but rather that long-term culmination of those trauma experiences. And so when that happens, typically one of the things that we see on the top, which would represent the top of the iceberg, is what we see are those behaviors that come out in somebody who is struggling with an eating disorder or with a substance use disorder. So at the top, what you may see are those maladaptive behaviors and coping, that emotional avoidance that may come along with it. And when we think about emotional avoidance, there's often difficulty for that person, to identify, to express, or to tolerate the emotional experiences that they're having. So what happens is emotion suppression or masking of those emotions. And what we end up seeing is that maladaptive coping or the dysregulation and the responsive behaviors that come along with eating disorders and substance use disorders. Hence, that you can sometimes only see the tip of the iceberg. And what we need to do, though, how we need to approach this is by seeing the behavior as a manifestation of what's going on under the water. The eating disorder or the substance use disorder was not the best solution at the time, but it was the best available one to the person at the time to manage the complex emotions and dysregulation. And so what the eating disorder and substance use disorder have in common is that they serve to numb difficult emotions that have threatened to overwhelm the person. It's like the drinking is not the problem, it's the absence of other coping mechanisms that causes a person to utilize the substances or to, restrict or binge and purge with an eating disorder. And this goes back ultimately to the previous few slides that I had discussed about the shared relationship of a disposition or temperament that is, a super feeler or hypersensitive, or for people who are very empathic and feel things deeply and are more prone to feeling overwhelmed by those feelings. And so to cope, there is that numbing and trying to escape from that emotional experience. And during that period of numbing and you aren't using those other coping mechanisms, that's when the eating disorder behaviors and substance use behaviors can be really prominent. And when I think about this, I can't help but also chat about anxiety and depression, which are two shared comorbidities of eating disorders and substance use disorders. So someone who is anxious and usually cannot stand to be in the skin they're in, or somebody who is depressed and may not be able to activate themselves or to get out of that intense experience of negative emotions, And so when combined with eating disorders and substance use disorders, they serve as the function to numb all of that out. And so when combined together, especially with trauma experiences, this all can be very powerful. So I want to talk about the challenges with concurrent treatment. So now that we've talked about prevalence, impact, and the influence of shared factors, comorbidities, when we talk about concurrent treatment specifically, there are a number of challenges that come to mind. And so one of the biggest things is the disorders themselves. You've seen that from the impact when we look at mortality rates and risk for suicide. And when you couple all of that with the additional psychiatric factors that are often present, it can be, these disorders are extremely complex. They can be chronic and have high relapse rates. And from the client perspective, when we're still focusing on the disorders, what comes along typically with eating disorders and substance use disorders, especially at the beginning, is denial and treatment resistance. And so that can be very, very challenging when we're trying to utilize concurrent treatment strategies. We also need to look at the system. And so challenges with concurrent treatment when we look at the system is that there really is a lack of concurrent programs that are out there. And a lack of specialized training opportunities. And so what ends up happening is, we have silos in treatment or sequential treatment. And so, an individual may be seeking treatment for their eating disorder and, not qualify for a substance use disorder program until they have their eating disorder under control, or vice versa. And so when you have sequential treatment, ultimately you're not addressing those two things concurrently when they're both coming up. And so what we need is we really need strength of evidence. We need more opportunities to look at these two disorders together. And we need to look at the impact of efficiency and effectiveness of treatment and long-term treatment outcomes. And so these are just a few of the things that I've highlighted with the system that can make it quite challenging. And I'll come back to that towards the end with some key takeaway messages. So when it comes to my second goal of the presentation, it was to highlight what we do at Bellwood Health Services and how we approach concurrent treatment. So I can't do a presentation without showing you our beautiful facility. So we are, as Jeremy mentioned, we are located in Toronto, specifically in Leaside. And this is a picture of, in the beautiful summertime, and it just gives you an idea of the environment that our clients would be coming to when they come to Bellwood. So what I'll do is, as we talk about Bellwood and what we offer there, I wanted to highlight a few key important things. So we have the privilege of having a very strong clinical team, and so as I know that as people from my organization are looking at this, I apologize if I've missed anyone, but I'll do my best to capture everyone that is a part of our clinical team. And so, with having evidence-based programming and different treatment streams at Bellwood, we need a clinical team to support that and to deliver the high-quality care that is part of our mandate, part of our mission to provide patients, clients with the best treatment, regardless of what treatment program they're coming into. So we have the opportunity to work with, the clients have the opportunity to work with physicians, nurse practitioners, psychiatry, nursing, mental health and addiction support workers, physical health, registered dietitians and nutritionists. We have substance abuse workers and addictions counselors, social workers, psychotherapists, occupational therapists, and then we have our client navigators, our case coordinators, and we also have research coordinators as well. I would be remiss if I did not mention a few of the other people that are there along with the client journey, such as our admissions staff, our admissions counselors who work with the clients, or our corporate care specialists who work with the clients at the beginning of their treatment, as well as our alumni relations department, which is a huge part of what we do at Bellwood. So I'll take you through an overview of our different treatment streams, and then we'll get specifically into our eating disorders program, which offers concurrent treatment for substance use disorders. So when we look at our treatment programs at Bellwood, we are a 100-bed facility. Most of our clients are coming for what we call long stay treatment. And so, and typically are within one of these different treatment programs. Sometimes individuals do come in for one program, and then they may transition into another depending on what their needs look like. So our core program specifically is a 7-week treatment program. It focuses on CBT as well as DBT skills and relapse prevention. We have a 7-week mood and anxiety program, and that focuses on CBT as well as acceptance and commitment therapy, DBT skills, and it also includes OT sessions, individual OT sessions where the focus really is on community reintegration and skill translation. We have our trauma recovery program, which is an 8-week treatment program. It is a cohort model. So what that means is we bring individuals in at different intervals so that they can go through cognitive processing therapy, which is our main treatment modality within that program. They can go through that in a modularized manner, so which is the way that CPT is designed to be carried out. And so within the trauma recovery program, there are 2 different treatment streams. We have the core or the MAP stream. And so in addition to the CPT sessions that clients will transition through in that throughout their modules, they're also getting either core content or mood and anxiety content, depending on if there is substance use present or if they're there for a mood and anxiety disorder. We have a few other programs which are a bit shorter stay. Our Return to Wellness program is a 14-day treatment program that focuses on intro to skills groups, and then a transition to our intensive outpatient services, which is offered by EHN nationally. We have a comeback program. This program is a 10-day treatment program, and it's meant for clients who, after a period of stability, they require a booster, and so it's about skills enhancement. We have a partnership with Sunnybrook Health Sciences Center for our obsessive compulsive disorders program, and so they offer a hybrid inpatient and day treatment model. And then what I'll do now is I'll take us specifically through the eating disorders program at Bellwood. And before I get to that, though, I want to talk about the treatment journey at Bellwood in general. So when we think about the treatment journey, I want you to keep in mind that all of those clinical staff that I had on a previous slide are supporting all of our clients who are in treatment at Bellwood. And ultimately, I kind of look at the treatment journey as having different phases. So we have our pre-admission phase, we have our treatment phase, and then we have our post-treatment phase. But I'd like to talk to you about each of those. So before a client comes in, any client, regardless of what treatment stream that client may be interested in or the referent may be interested in, there's an admissions assessment that's completed with the client. And we do that to gather information and really try to understand what it is that the client is coming to us for and what their needs might be and how we can best meet those. So typically there's treatment matching that we will do after we have worked with a client. And typically we have multiple conversations with clients before they come in to identify what would be the best treatment program for them based on their needs. There's clinical consultation within that as needed to help for us to help identify which program may be the best option. And then, of course, there's an admission plan. When is the person coming in and what will their treatment program look like? When we go to the next phase of the treatment journey, when the client comes to us and is in-house with us, on admission day, there's a nursing and medical assessment that's completed with a client to help identify what their baseline needs are from when they come in our doors and they're accepting treatment from us. And so clients have access to 24/7 medical care and support staff. We have 24/7 nursing and mental health and addiction support workers who are on site with clients at all times. We also have the opportunity to have psychiatric assessment. So that's, so it's kind of done in two ways. So program specific, so our mood and anxiety program, individuals are receiving that, as well as with our eating disorders program. That's built into the care that they receive. And then if a client presents with needs throughout treatment, we may have a psychiatric assessment as well. Detox and stabilization are of course included, and so that typically ranges from the first few days of a person's admission, if required, and it's very individuals. It's independent, so it depends on what the individual's needs are and their intensity of use before they've come to us, and that period really is focused on stabilization. And then when we think about the treatment programming and the program that the individual would be there for, we really take a holistic approach. And I'll talk about that specifically. And then, of course, post-treatment planning. How can we help the individual to be successful when they leave? So when we look at holistic treatment programming, and again, this is across the board, regardless of what program the client is in. So it's inclusive of eating disorders and our concurrent eating disorders and substance use disorder program. So our programming is trauma informed, and it is largely delivered through group therapy. And so individuals have primary group therapists. So for example, if I am in a CBT group and I'm doing that several times per week, I'm typically getting the same therapist for my group sessions during the week, and that helps with continuity of care and skill building. All clients are also assigned a primary individual therapist to help really enhance the skills that they're learning and the therapy that they're doing, but on the individual level. All clients have access to nutritional support, health teaching and education, art therapy, and system navigation. And then, of course, all clients have access to physical health, which can include, we have gym facilities, nature walks, yoga, meditation, team sports. Volleyball is a favorite. And then we have wellness opportunities as well. So acupuncture, massage therapy, chiropractor. And then we have a number of self-help groups that are available to our clients, that our clients are required to attend. So whether that's Alcoholics Anonymous, Narcotics Anonymous, SMART, Gamblers Anonymous, and clients are also able to, if they have a self-help group that let's say that is from their home community, they're of course able to continue with that because they've already established that as part of their recovery network outside of Bellwood, and we want to encourage them to maintain that. There really is a big focus at Bellwood on the recovery community specifically. How can we help you to develop your community of people, your community of support while you are with us to help transition you back to your life outside of Bellwood? And a big focus for us is also on relapse prevention and post-treatment planning. So again, across the board for all programs, inclusive of our eating disorders and substance use program. Family support. So there are two opportunities available to everyone who accesses services at Bellwood. So that's our family workshop. It's a 2-day workshop event held on Saturdays and Sundays, and it's specific to what we are doing at Bellwood and what that looks like. And then we have our family process group, which is for EHN nationally that people have access to. And then after treatment, if required, we have our EHN intensive outpatient services. So sometimes what we see is that clients who have accessed care at Bellwood, they may benefit from this step down service, and so we would make that recommendation and connection. And all clients who complete treatment are also eligible for 1 year of aftercare, which really focuses on skill enhancement and relapse prevention. And of course, our clients have access to our Thrive alumni community, which is a national alumni network, where there are events that are regularly put on. Some are Ontario specific, and then of course there are other events that are happening at our other organizations, as Jeremy outlined at the beginning. So when I get into the specifics of the eating disorders program, my goal here is to point out some of the additional features of this program, in addition to what I've already discussed that clients at Bellwood receive across the board. So when I think of with our ED team, we have what I would call a mini team within the greater team. So there is an eating disorder specific psychiatrist, as well as psychotherapists within this team, a registered dietitian who's dedicated to this team, as well as a nutritionist who supports this team. And our mental health and addiction support workers have specialized training in meal support in order to meal support and skills in order to support clients who are in the eating disorder program. The ED program is referral based. Clients typically come to us through a variety of avenues, whether it's self-referral, physician, referral partner. And there is a pre-admission psychiatric assessment that our eating disorder psychiatrist does specifically with a client. And it's not only to determine eligibility, it's also about treatment fit and treatment match, and really establishing what the client's goals are for treatment. It is a very goal-based program. What do you need? How will this be beneficial to you, especially from a concurrent perspective if there is concurrent substance use? And so in general, the program is 8 weeks. Sometimes it can be extended longer than that, depending on the individual's needs. And so when we look at that, some of the things that we're looking at is, what does the client need? Next slide, Jeremy. So what does the client need? If a client is accessing our eating disorder treatment, is there comorbid mood and anxiety? Is there comorbid substance use? Is there comorbid trauma or PTSD? Are there process addictions? Will the client benefit from relapse prevention skills? And so what we want to do is, when we look at those goals for that individual, is really have the ability to customize their treatment. And so while an individual may be following their treatment program that's well defined within the eating disorders program, what can we add on to help this individual to meet those goals? So the key here ultimately is in-depth assessment and to create that concurrent goal-based treatment plan. And so that's what we aim to do. When we look at the content, so what clients in the concurrent ED treatment program will be doing when they're with us, it really is about the following. So there's psychotherapy and skill acquisition. As I mentioned, our programs are largely group-based. And so in the eating disorders program specifically, that's looking at DBT as well as CBT, in addition to specialty groups like body image, meal planning, process groups, and exposure work. And so that may happen that happens in the group setting. And then we also have the individual support as well. The individual therapist, it's their job to go do that deeper dive with the client, with the individual, to really help them identify what it is that's going on for them, and how the skills that they're learning, how we can enhance those. And there may be additional exposure work that happens individually as well. Our family therapy sessions, which is in addition to the family workshops and the family process groups that is available to everyone, the family therapy sessions that are available within our concurrent ED program are actually led by our psychiatrist. And so that's an opportunity for family and loved ones to really work with the client who is in treatment, and for us to help transition them as they progress through their treatment program. I mean, as an ED program, we of course have, the typical components of any other ED program. Where we focus on symptom interruption where we need to, as well as symptom monitoring, and how clients can translate that back to their own environment when they leave. Not all clients are coming to us for weight stabilization. Some clients certainly are, and then other clients are more focused on, that symptom interruption, and how to maintain what the gains that they've made before they've come to us. And then while there's a big focus on, that holistic approach to care at Bellwood, and access to physical health opportunities, we really do customize that to an individual's needs. when they come for our ED program, and to ensure that that what they're engaging in is being done in a healthy way, and something that is realistic, so that they can translate that back to their home environment. Nutritional rehabilitation is, of course, another cornerstone of the program. So this photo here is of our teaching kitchen at Bellwood, and so what we really focus on is nutrition education, meal support, meal planning, exposure work, and then that skills translation as well. So when we think about all of that, I want to highlight some key messages. So when we think about concurrent treatment, and why that's so important, ultimately it's about continuity of care and the client experience. When we don't have concurrent treatment and clients are doing things sequentially, it really becomes a game of whack-a-mole, which is my graphic that I've included. And so if you are only treating the eating disorder and you treat that, you may be able to manage that and maintain some gains in that area, but then what may happen is the substance use may go up, or vice versa. If you're only treating the substance use, the eating disorder may go up. And that really speaks to when we were talking about those shared risk factors, the comorbidities, the influence of trauma, and how people regulate emotions, and the fact that there's nothing more powerful than an eating disorder and a substance use disorder combined. And so what we know is that they actually can be mutually reinforcing to each other, and so that's one of the main reasons we need to do this work concurrently. So when we think about that, that's one of the main reasons for concurrent treatment. Those optimal clinical outcomes, managing the relapse risk, and looking at long-term recovery for individuals. And of course, we can influence the mortality rate, because what we know is that when these two disorders are combined, that's actually quite significant. And then social and economic outcomes. This wasn't something that I had time to discuss in great detail during this presentation, but what we know is that, when eating disorders and substance use disorders go untreated, there are significant social and economic impacts: lost productivity, costs to the healthcare system, and those numbers are actually quite staggering. So when I think about those key messages, what I'm hoping that we take away from this is the importance of screening and assessing for both eating disorders and substance use disorders. And so identifying what are those treatment opportunities, how can we make concurrent treatment the priority as opposed to sequential. I think we really need to examine the silos in practice that exist, that come along typically with that sequential treatment. If I am an eating disorder program and an exclusion criteria is substance use, I'm playing that game of whack-a-mole, and is that really helpful? And we know that the answer is no, but it's actually very difficult to find those concurrent treatment programs that are out there and available. So we really need to examine those silos and try to bridge those gaps. We need to invest in training and education, as well as advocate for services and programs and invest in research. A few of the studies that I referenced today are very recent, within the past year to 2 years, especially the meta-analysis that looked at the mortality of substance use and eating disorders combined. And so it appears in the literature that it's only been in recent years that this has become a priority to focus on. And then when I think about training and education, having spent the past 10 years working in mental health and addictions, I haven't been in a training or education opportunity where things are done concurrently. It's only been in the past year or so where I've really been able to focus on that and try to create those opportunities. And so as someone who's worked in the industry for quite some time, if I haven't had that access, that means that many of us maybe who are on this webinar today haven't either. And so we need to make that a priority, where we look at investing in training and education, as well as in research to help us better inform evidence-based treatment programs, and so that we can advocate for those programs and services. And then when I was creating this presentation, I was speaking to a few members on my team, and I asked them for their perspective on why concurrent treatment, and why does this matter, and why do we need to ensure that this is the message, and that this is how we approach concurrent treatment for eating disorders and substance use disorders. And he said to me, it needs to be the chicken and the egg, not one or the other. And so I found that that stuck with me. And so I wanted to include that here for you today. So with that, all of that information, we can go to questions, and I hope that I can answer some of those for you.
Perfect. Thank you so much, Cheryl, for that great presentation. Yeah, lots of questions coming in, so I can just get us kind of going. There are some questions specifically about the age ranges for the program at Bellwood. So if you could kind of speak to the age range that Bellwood treats.
Yeah. So in general, our programs are for the adult population, so 18 plus. And so what we see, we have a huge range of clients who are accessing our treatment programs. And so while there certainly may be some individuals who fit more within that transitional age youth kind of spectrum, typically in the literature that's like 16 to 24. We also certainly have individuals who are in their 40s, 50s, 60s, even 70s who come and access our treatment. And that's very much true for our eating disorders program. And so if we look at the literature, there's evidence to support that, of course, programs, for individuals who are age related to each other can be quite successful. At the same time, one of the things that we focus on at Bellwood is the fact that when you're in a community, I highlighted all of those different programs that we have at Bellwood, and when you're in a recovery community and you have the ability to learn from others, regardless of what age you are, the perspective that they may be able to bring to you, which is why we focus so much on group treatment and creating that recovery community. It's very, very helpful to the individual.
Absolutely. Thank you so much. There are some questions too about the inpatient programs versus outpatient programs, online, all that kind of stuff. If you just want to speak to the nuances of that.
Yeah, and I think, I could do a presentation in and of itself on treatment intensity and matching to treatment needs. And so at Bellwood, that ultimately goes back to that pre-admission assessment. And so typically when people are coming to us, and accessing long stay treatment, which is what we tend to refer to it as Bellwood, they have typically gone through those other programs. Yes, the dog jumped up in the back. I see a few comments coming. Typically people have been through those lesser intense programs, and those have not met their needs, which is why they are coming to a program like Bellwood or any other inpatient or long stay treatment, because it hasn't met their needs before. So it depends. It depends on what the client needs and what they've exhausted. Typically, you want to exhaust the lower intensity services first before you go to the most intense services, but it depends on how significant either disorder is. But I'd certainly be able to, we could do a follow-up on that, Jeremy, if we wanted to.
Hey, yeah, you're getting into it now, so. Then there's some questions too about like wait lists compared to the public system, and then also funding through public system and government entities too.
And so our eating disorders program so typically we have up to 6 individuals in the program at any given time, but we are a private treatment facility. However, what we do is we typically work with a variety of referrants. So as I mentioned, some clients are coming to us through self-referrals, so they may be private pay, or there may be individuals who have received funding from their province for ED treatment, or we're working with referrants with established relationships, and this is specifically what that client may need. And so we always have flexibility. So I would say that from my experience, I worked in a residential eating disorders program. It was a provincial program, and the wait list was quite long. We don't face that same challenge because we have greater flexibility and things are very goal-based. And we have access to a continuum of services within EHN, which can be very helpful to people. So if you have somebody that may be interested in treatment at Bellwood, I certainly would encourage you to reach out. And then we can give you a better awareness of exactly where things stand. But certainly don't let the idea of a long wait list deter you. Ask us and we can help answer that.
Absolutely. Yeah. I was just going to reiterate with like working with the admissions team and the corporate care specialists, they do a very good job of seeing all the different avenues you can explore for cost for treatment, for wait lists and all that kind of stuff, inpatient, outpatient, virtual, whatever it may be. So whenever people reach out, I always reiterate to just contact us because we'll for sure try to explore every avenue possible. And then there's some questions specifically about the role of the dietitian. So if you could explain a little bit more about the role of the dietitian within the eating disorder program.
Yeah, every individual that comes in through the eating disorder program is supported by a registered dietitian. And so what we are looking at there is ultimately, what does the individual patient need? Do they need weight restoration? And therefore that will be reflected in their meal plan. And it's typically a progressive meal plan if the goal is weight gain. If the goal is stabilization, then that would be reflected in the meal plan. And so ultimately the role of the dietitian is to help that client progress and to meet those goals. Eating disorders are exactly that. They are eating disorders. And so the control of food and intake. And so how do you target that without a dietitian? You need the dietitian there to help inform what that plan looks like along the way, and also to provide the education and the support, and to kind of make that connection between the eating disorder as well as the emotional avoidance and how to help break through that.
Yeah, absolutely. Thank you so much. And then there's just a couple questions too about like the length of the program. I know we spoke to it too, but is there like wiggle room? Is there varying for different patients and such?
Yep. Absolutely. And so the key here is goal-based. So if you are a client who comes for the eating disorder program, and let's say you have very specific goals, if you achieve those goals within 6 weeks, that's a conversation that we'll have with you. We may then discuss with you about staying for the entire treatment and focusing on relapse prevention. Again, it goes back to the ability to customize. So yes, you might have met your goals on paper. However, what we know is that eating disorders and substance use disorders are much more complex than what people than what we can see. It's like that iceberg. What you typically see at the very top is not the whole picture. And so for an individual, that's where we would say, okay, you might have met those goals on paper. However, here is as a team, what we're recommending that you focus on now. And then we may have that individual go to the final 2 weeks of relapse prevention that's featured within our core program. So it's customizable, but it is goal-based and driven by the client in terms of what those goals are.
Perfect. Thank you so much. Unfortunately, that is our time. There's a large variety of questions as well, but we'll try to do some follow-up resources and maybe a continuing webinar series too. So
we packed a lot in there.
We did. No, again, just to reiterate what everybody's saying in the chat, informative, concise, so much variety within the topic too. And I love the analogy you used with the chicken and the egg, because people are reiterating that. They're like, it's important to realize that it's both, not one before the other, like you specified. So thank you again, Cheryl, for your insight and expertise. And to everyone else, thank you so much for your attendance today. We will be sending a follow-up email sometime mid to late next week that will include a copy of your CEU certificate, a copy of today's presentation slides, as well as any additional resources. And then we are also hosting a new webinar on February 9th about the impact of mental health and addiction on the family. Stay tuned for that invite. And until then, take care.